Good morning, everyone. I'll be talking about redirecting the misdirected, navigating the treacherous currents of aqueous humor. So basically, we had a 65-year-old male present to us with a visual acuity of 6 by 12 in the right eye and 6 in the left eye. He had a intraocular pressure of 10.2 millimeters of mercury in the right eye on 1 anti-glaucoma medication and 31.5 millimeters of mercury in the left eye on 4 anti-glaucoma medications. Patient was pseudophakic in both eyes, and significant past history included that he had undergone a right eye trabeculectomy in September 2022, following which documents noted that he had a shallow anterior chamber, though he had a patent PI, closed angles, and a high intraocular pressure on maximal medical therapy. So for that, he had undergone a repeat trabeculectomy along with an anterior vitrectomy in January 2024, following which his intraocular pressure in the right eye was controlled at 12 millimeters of mercury on 1 medication. So when he presented to us, this was the status of both eyes. The right eye showed a low-lying bleb with a formed anterior chamber and an intraocular pressure of 10 on 1 medication, while the left eye showed a shallow anterior chamber, which was shallow both in the center and in the periphery, and he had an intraocular pressure of 31.5 millimeters of mercury on 4 anti-glaucoma medications. Fundus evaluation revealed an advanced cupping in both eyes around with a cup disc ratio of around 0.85 with a more prominent inferior rim thinning in both the eyes. On gonioscopic evaluation, the right eye showed open angles in all quadrants along with a patent sclerostomy in the superior quadrant, while the left eye, no angle structures were visible in any of the quadrants. So looking at the axial length of the patient, we found that the patient was fit the criteria for mild to moderate myopia, had an axial length of 23, so was not really fitting into the category of the classical primary angle closure disease, but PACD has been reported in up to 13% of patients with myopia previously too. So anyway, what did we decide to do with the patient? We thought we'll go ahead with the left eye trabeculectomy plus MMC in view of the uncontrolled pressures. But post the trabeculectomy at 1 week, we saw that the patient now had a visual acuity of 660 with an IOP of 22 millimeters of mercury. The bleb was shallow and the anterior chamber was also uniformly shallow, even though there was no iridocorneal touch. And on dilated fundus evaluation, no supraciliary effusion could be noted. So this got us thinking what could be the various differential diagnosis for this patient. A choroidal detachment seemed unlikely because the patient had high intraocular pressures and fundus evaluation was normal. A pupillary block could not be there since we already had a patent peripheral iridotomy. A suprachoroidal hemorrhage was also ruled out by good dilated fundus evaluation, and a wound leak would have presented with a low intraocular pressure, so that was also ruled out. So this got us to the diagnosis of exclusion, that was now malignant glaucoma, for which the patient was fitting all the criteria of having a shallow anterior chamber with an elevated IOP and a normal fundus evaluation. So this was a final diagnosis of aqueous misdirection or malignant or ciliary block glaucoma. So now we proceeded, we decided to go ahead with the management, and the first step was to administer the patient cycloplegics and aqueous suppressants, but this did not really help the patient. So we moved on and decided to go ahead with the AC reformation. This did not really help either. The next step we did was we did a core vitrectomy to reduce the vitreous volume along with the coexisting AC reformation. But even despite all this, the patient still had an intraocular pressure of 22 millimeters of mercury and a uniformly shallow AC with almost impending iridocorneal touch. So now we were thinking that the AC is still shallow, the IOP is still high. What should we do now? So our surgical options included that we could either go ahead with the repeat AC reformation, we could put in a drainage device implant, a YAG hyaloidotomy, or a iridozonal hyaloidovitrectomy. So we decided to go ahead with this. Iridohyaloidozonulobitrectomy. Yes, sir. So as you can see, the chamber is very shallow. Even when we tried to introduce an air bubble, it would not stay in the anterior chamber. So we went ahead, we made a peripheral surgical PI, and after that the chamber was still pretty shallow. We tried to form the chamber with high viscosity viscoelastic, but that did not really help either. Then we went ahead, made another port, and using a 23 gauge vitrector, we advanced to the surgical PI that we had created and turned the vitrector face down and decided to cut the zonules followed by the hyaloid. A vitrectomy, core vitrectomy had already been performed for the patient, so we did not really need to go that posteriorly in this patient. And here we have cut the zonules, and as soon as we did that, we saw that the anterior chamber suddenly deepened. As you can see right now, we'll try introduce another air bubble, and now the air bubble is able to stay in the anterior chamber very nicely. So post-operatively, this patient at 1 week had a visual acuity of 618 and an IOP of 7 millimeters of mercury on no anti-glaucoma medications. The pathophysiology can be varied. One of the theories suggests ciliolenticular block due to a forward rotation of the ciliary processes. The aqueous humor can't flow into the anterior chamber and collects in the vitreous cavity. The other school of thought is that sudden hypotony leads to a blood aqueous and blood retinal barrier breakdown, leading to protein leakage into the choroid, thereby water retention and an increased volume in the posterior chamber, leading to anterior push and a compensatory volume loss from the anterior chamber, leading to a self-propagating cycle of anterior chamber shallowing. Triggering factors can be any incisional surgery or sudden shallowing of the AC, acute angle closure attacks, overfiltration post-glaucoma surgery, plateau iris, YAG capsulotomy, or miotic induced. And cases of development of malignant glaucoma have been reported even 8 to 10 years post-uneventful cataract surgery. This is just a flowchart which tells us how we should go ahead with the management in case of acute or chronic. And the take-home message is that this is something that we should always keep in mind. And the treatment is pretty simple once we get to the diagnosis. Thank you.